Hello, good afternoon, everyone. Thank you for joining us for the Echo session today. My name is Jody West, now Strother, sorry, and I am the coordinator of the Tele-Echo session. I wanted to go ahead and go over a few housekeeping, there we go. Housekeeping before we get started. We're going to go through this agenda. We're going to stick to our timelines as much as possible. This is our perinatal mental health tele-echo, and we're going to do some introductions to our hub team. Then we'll move to the didactic presentation, and then we'll have some time, a few moments for some questions, and then we'll move to our case presentation, and then we'll wrap up. I am the coordinator of the ECHO, but I am the program manager for the provider to provider consultation line, which is a mental health consultation service that's available to providers across the state. And we provide consultation for case-specific questions that you may have as a provider that works with families or children. Our two focus areas are pediatric patients, which is 0 to 21, our perinatal and 1-year postpartum patients and clients. So you can give us a call to talk with the social worker and a psychiatrist if needed for medication and diagnosis question. We also offer trainings, and this Tele-Echo series is one of them. So if you are not familiar with this, you can scan this QR code and it'll bring you to our webpage and where you can register, but you can also look at previous Echo sessions if you're new to our program and see some of the topics that we've covered, as well as look at the schedule for upcoming presentations. So another introduction I want to make is Lena Reget. She is the mental health clinical supervisor for PPCL. She is helping me with the logistics and the behind the scenes work of the ECHO. She is a social worker, and many of you have probably spoken to her when you've called. So I just wanted to introduce her as well. And I'm going to go ahead and hand it over to Dr. Finelli, who's going to facilitate the rest of the session.
Thank you, Jody. I'll introduce myself, Juliana Finelli. I'm a child and adolescent psychiatrist and a general psychiatrist, and my clinical focus is perinatal psychiatry and infant and early childhood psychiatry. And I serve as a perinatal psychiatric consultant for PPCL and as facilitator for this tele-echo. And thanks everyone for joining us. I'm going to pass it on to Dr. Zena, another member of our hub team, to introduce herself.
Good afternoon, everybody. I'm Paula Zena. I am a pediatric nurse and a clinical psychologist, pediatric psychologist. I am a professor in the Department of Psychiatry at Tulane. My clinical background is varied. I spent many, many years in the maternal, infant, early childhood mental health, not mental health, home visiting program through the Office of Public Health. I'm currently doing a lot of work with the Trauma and Grief Center at Children's Hospital and also with the Tulane Comprehensive Assessment and Treatment Center team there.
Thanks, Dr. Zena. I should have said I also work at Tulane with Dr. Zena. So I'll pass it on to Katie Abear, if you want to introduce yourself.
Yes, hi, I'm Katie Abear. I'm a LCSW working in private practice at Bloom Mental Wellness in Lafayette, Louisiana, and I focus on the perinatal population.
Thank you, Katie. And I think Jody introduced Lena for us, so that's our hub team. And I'll pass it on. I don't know if there's any other housekeeping, Jody, or if we're ready to move to the didactic portion.
Yes, Sam Roberts is going to present for us. Sam, I'll go ahead and I'll promote the slides. Let me go ahead and do that now.
Okay, thank you, Jody. Hi, everybody. I'm so grateful to be here today presenting on a topic that is near and dear to my heart. We are going to be talking about holding in perinatal mental health. Some of you know me, some of you may not. I'm over here in Baton Rouge, and I am the founder of Baton Rouge Perinatal Counseling. We came together during COVID. There were a handful of us perinatal therapists in private practice in Baton Rouge at the time when COVID hit, and we were all very disconnected. And so it only made sense during that time to try to all come together and resource as a team, funnel referrals, share resources, communicate with one another. I come from the philosophy that no one should be doing perinatal work alone. The more eyes and ears we have on these cases, the better turnout for the clients and the families. And so we're basically a network of specialists over here in Baton Rouge at this point. Over the last couple of years, I've been able to bring in some students, and I think I even have one or two of the grad students on the phone call today, which has been such a privilege to be able to get the students early and start to specialty train them in perinatal mental health. But for today, we're going to be talking about holding, which is a very, very specific skill coined by Karen Kleinman of the Postpartum Stress Center. So over the last probably 6, 7 years, I have been working with Karen as a professional mentor, and I've now been to the Postpartum Stress Center 3 times at a certain point. Some of us at Baton Rouge Perinatal got to go train with her in person during COVID, and it was a wonderful experience. So I'm going to be bringing in a lot of her quotations and a lot of her research. And if you have any questions along the way, feel free to ask. So next slide. So for today's training purposes, given that it is a very therapeutic intervention, I would like you to just kind of suspend everything that you already know about perinatal mental health and open your mind to the possibility of other ways of doing this work. Holding is so much about the relationship between the provider and the patient. And so when we look at the research and what the research says about the number one tool in the therapeutic room is the relationship itself, holding is really about what does that mean? What energy in that room and what does that relationship really do in order to make therapy effective? So I just love this quotation from Karen Kleinman. When holding a postpartum woman in distress, you ride together on this journey, holding her truth, her story, and her interpretations. It requires a condition of complete openness to any possibility. She may not say what we expect her to say. You may not hear what you imagine she will hear. It requires listening to the voice of a heart that has been broken to words which may or may not accurately reflect the seriousness of the moment. Next slide, please. Karen Kleinman is the founder of the Postpartum Stress Center and now the Karen Kleinman Training Center. I cannot emphasize enough the trainings that will entirely change your practice, how you work with perinatal women. Through some of these trainings, they're very experiential, they're very conversational. So much about Karen's work is about you as the clinician and how you take care of you while working with these women, because oftentimes we get into this field given our own personal experiences and our own reproductive stories. It is so very important for us as providers to be able to contain our own reproductive stories enough to be fully there for our patients and our clients and their families in the room. However, you just never know what's going to walk through your door and what may trigger something that you thought you might have been past. It could be 5 years from that experience or 20 years down the road from that experience. You just never know what case that you're going to be working with that may uncover some physiological experience in that room, and you need to be prepared to be able to manage that situation professionally in order to be able to help your patient. So the art of holding in therapy is really, really kind of like the Bible for any clinician who works with women in the perinatal stages of life. So this book is for us as clinicians in this space when working in that room with the clients in particular. Karen's also authored several foundational texts on maternal mental health. This is just an example of some of the books you probably recognize. Good Moms Have Scary Thoughts. What About Us is in regards to the relationship and what happens to the relationship once a baby enters the marriage or the relationship, the family afterwards. She's also got some coloring books, Moods in Motion is what that's called, and various others. There's also a third book in the Good Moms Have Scary Thoughts series coming out on perinatal OCD, which is really exciting. And these books are wonderful because ain't nobody got time to read in postpartum. They're filled with comics and very relatable thought bubbles. And so we can use those in a holding relationship as part of an active intervention when you're working with the clients. Sometimes I'll just kind of tab a few of these pages and bring them out, especially when we're psychoeducating those clients on there is a name for this. This is something that we know how to treat, and we can help you with that. And clients are often very relieved to know that somebody knows what we're talking about. Holding is truly an art. Your clients will not be listening to your tools unless they feel connected with you. And so the art is the piece of connecting. And how do we do that? We have strategies to do that, but at the same time, and Karen laughs about this, holding is something that you don't know that you're doing when you're doing it. And oftentimes it's hard to put into words. So we're going to talk a little bit about that. Go ahead to the next slide, please. What differentiates a perinatal provider from a holding therapist? Within the context of treating a perinatal woman in distress, wisdom is the balance between what you know and who you are. So again, that self-awareness about your own reproductive story is wisdom. So it's taking what you've learned about your own healing and it's balancing it with what you know clinically and being able to offer such non-pathologizing, comforting space in that room. You know, as the clinician, we're working with diagnosable issues, but you're offering a helping environment where we can feel and create a space as normalizing as possible for your clients. Next slide, please. Okay, so bringing it back to grad school, who remembers Donald Winnicott? Winnicott was a pediatrician and psychoanalyst. Karen's work draws a lot from his theories that he developed. The biopsychosocial context in which an infant's needs are met by the mother or primary caregiver. He coined this concept of good enough mothering. Good enough is goal for perinatal women, but oftentimes perfectionism and other unrealistic standards set the tone and put them at risk for postpartum depression and other mood and anxiety disorders. So Winnicott creating this idea that you don't have to be a perfect parent, you only have to be a good enough parent to meet the needs of your child. He also came up with this idea that children develop into either a true authentic self or a false sense of self based on whether or not their needs are met. But you only have to truly meet the needs by being a good enough parent. And if those needs have to be overcompensated by a child, that child will unfortunately develop a false sense of self, which will have to be corrected later. Good enough mothering is actually also applicable to good enough clinician, good enough therapy. And so goal for holding therapy is also good enough clinician, because through perinatal therapy and through holding therapy, we can acknowledge that mistakes are going to be made. When you're working with a client long enough, one of you is bound to either be late, be sick, have to cancel, et cetera, et cetera. And so what holding therapy really teaches us is that as clinicians working in this field, your therapeutic relationship is really going to emulate what a real and honest and true relationship is going to look like in the real world. And so we are teaching our clients to be able to tolerate those experiences through your relationship that you're developing. When Winnicott first developed his research, he gave this experience or development. He portrayed development from complete dependence of an infant, relative dependence to eventually independence as a successful transition into adulthood. And so that concept of relative dependence is really like what we're comparing holding therapy to. You're basically the container for that mother in her new development and her new identity. And she's coming to you and bringing her distress as you're the person who's been trained to hold those conversations and have those conversations with her that nobody else is having in her life. You're the one who's asking her the hard questions. You're the one who's tolerating the anxiety that maybe her mother doesn't or her husband can't quite understand. And we're teaching her that through us, by being able to tolerate the distress that is so hard for her to talk about, that she can do the same. Oftentimes, creating a space to say those things out loud is most of the work. And a lot of us know that. Okay, go ahead to the next slide, please. So what is holding really? Holding within the context of therapeutic work with perinatal women is defined as a loss-informed, strength-based approach, which provides prompts and specific skills to enable the therapist to contain high levels of distress and do so in a way which cultivates the early stage of connectedness. This attempts to contain the client's symptoms of agitation and despair is accomplished despite the innate pull the client feels to repair this herself in order to preserve what she perceives as her dwindling sense of control. And so just take a look at this photo. I thought this was a really good photo of a clinician who's doing a good job of holding. What do you notice about her? She's got a very soft smile on her face, a very endearing look. She's relaxed in her posture. She's got a welcoming energy about her. Baby is on lap for mom, right? Babies are welcome in session. Oftentimes, you can learn a lot from working with a perinatal woman when her baby is with her, even if it makes it a little bit more difficult to assess certain symptoms. You can also learn a whole lot by observing a mom with her baby. And I often find myself commenting and encouraging how she's tending to her baby in session, because she oftentimes may not get that positive reinforcement. And so this is a very good image of a therapist who's modeling maybe an expert, but also a relationship that is mutual. Next slide, please. So drawing from that definition of holding being a loss-informed perspective, we can understand that the presentation of perinatal distress is distinguished by the contradiction of how deeply a woman suffers, and then this resistance to disclose it, right? So this is the nuance of perinatal distress with which the Postpartum Stress Center puts out there. She is suffering so severely, but what she is doing, she's actually fighting the distress, because this should be the happiest time of her life, right? And she should enjoy motherhood, but so often she doesn't have the words to talk about how bad she's feeling. And so when we're working with her, if we can understand these symptoms as losses in her life, we can also empower her with the language of how to use the symptoms as part of the grief that she's experiencing, that this whole transition to parenthood is not going the way she thought. Why she may be feeling so bad, right? The incompatibility between motherhood and her sense of control, the absence of independence and also the baby's dependence. She's having a hard time asking for help, right? As women, we value overfunctioning. And this may be the first time in her life where she actually has to vocalize her needs, and that's very vulnerable. She may feel the pressure to bounce back or to look good because good moms look good, right? She's grieving the idea that motherhood, as she had always imagined it, her timeline for baby was her idea with her partner, and then the societal and cultural implications and the weights of her responsibility. So our brains during this time trick us into believing that our symptoms are who we are. But when we work in a holding framework, we're teaching her that those symptoms are what she has and not who she is. So we are teaching her how she can diffuse from her symptomatology, which is more non-pathologizing and being able to treat her therapeutically. Next slide. The complexity of postpartum depression is that the feelings and the strong emotions are expressed as symptoms and experienced as self. They don't feel like symptoms, they feel like who you are. So just can't emphasize enough that I am versus I have. And Karen uses this analogy of when you first get a perinatal client, it's like they're bringing in this big Tupperware of tangled yarn. There's a big ball of tangled yarn in the Tupperware. They're coming to us for help is like us taking the yarn out of the Tupperware and detangling it so that we can make order out of that one string of yarn that is all knotted up. Next slide, please. The holding framework is really setting up an experience, a space, and an energy. It's an art that's cultivated between client and provider. We must be able to acknowledge within herself, or we must create a space where she can acknowledge within herself that she actually does need nurturing, and that's okay. What is present, her internal narrative in response to the symptoms she's experiencing is actually authentic suffering. So teaching her to not resist it and that her feelings are actually quite valid. How often do we hear, but people have it so much worse, right? Or, but that's really not a big deal, right? Well, when we can put all of that aside and teach her that her story is legitimate and that her suffering is true, we're creating a very non-judgmental, shame-free space. We're asking how much yarn really is in there. What emerges? Dynamic forces unique to the perinatal population that influences, enhances, and disrupts holding in the therapeutic process we call holding elements. How much use is this? And what we do, how we respond to attunement, containment, and protection, we utilize what we call holding points. Next slide, please. So these are basically the interventions of the holding framework and the holding intervention. This is what I mean by you might be doing it already, you just don't know that you're doing it if you are an attuned clinician. Grounding is a skilled response and an intentional sense of being. This translates as I can help you and you are in the right place with your body language, with your verbals. This is your own awareness, and this is also where you keep from rescuing the client. The current state is a skilled assessment of her level of distress and functional impairment. We have to resist the temptation to fill in her narrative with your own reproductive journey here. This sends the message, I can tolerate your distress. You are in the right place to talk about this. It's also a rapid evaluation of the client's immediate circumstances, including physical safety, setting the stage for our therapeutic interventions. Being the expert is a skilled response to her symptoms and separation from the symptoms from herself. I know what this is and I can help you. You will not always feel this way. In this point, you must believe in your ability to help her. And that's the hard part. That's part of Karen's trainings that really help you start to believe from imposter syndrome into, wait a minute, I do know what I'm talking about, and being able to transfer that into your clients. Design is a skilled blueprint or treatment plan for symptom relief. It's not problem solving or suggesting, but it's determining the most urgent course of action. Presence, self-skilled awareness and authenticity in your being, a skilled response to authentic suffering. So you're sending the message, I can tolerate this distress with you. I know this is not who you are. We pause to take in the emotions and suffering when it is shown. There is nothing better than a few seconds of silence. And even though I'm talking a lot right now, in that room, silence is everything. And finally, safeguarding is skilled and ongoing assessment of vulnerabilities and strengths. You're basically sending the message, I am always looking out for you. I am always working for you, and part of asking the hard questions. And so finally, last slide, or next slide. She is your greatest resource and you are her greatest tool. Although there's no upside to suffering, we have all seen countless women transform in response to their painful experience with depression, developing self-awareness and personal insight. If you, as the catalyst for healing, can steer her in the direction of hope and reframe her symptoms as evidence of her strength and capacity to reach out for help, you have set recovery into motion. And last slide. Here are the links to the Postpartum Stress Center and the Karen Kleinman Training Center. I would highly, highly encourage y'all to look into the trainings that they have available. Postpartum Support International is wonderful, giving you high level, macro level trainings, and of course the PMHC credentialing. Postpartum Stress Center is really, really more intimate space, individualized and experiential. So for those of you who are working, in those smaller spaces, one-on-one, provider to patient or provider to client, doing the Karen Kleinman trainings or any of the trainings through the center may just be a very, very good bucket list training to keep in your back pocket. We do all kinds of things like little tips and tricks and tools, Russian doll experiences, and magic bracelets, to name a few. And usually working with the exhausted moms, doing little things like this are just visuals and tangible tools that give them things to remember coming out of your office. So that's all I got. Thank you for listening.
Thank you so much, Samantha, for that really wonderful presentation. We're going to save questions till the end, just in the interest of moving on to our case. And I just wanted to remind folks with our